Welcome, everyone. I'm Dick Deming. I'm Medical Director of Mercy One Cancer Center and founder of Above and Beyond Cancer. Welcome to our weekly cancer education series, our video podcast. And this video podcast is brought to you in part by a grant from the Rosalie and Sherry Exline Ziegler Fund. And tonight we have an exciting new topic that we're going to talk about. And our guest tonight is Michael Osborne. Welcome, Michael.
Good evening. How are you?
Great. Welcome. Michael's in North Carolina, and he's a North Carolinian through and through. His education has been at University of North Carolina, Chapel Hill, Duke, and Wake Forest, kind of the trifecta. He is a genetics counselor, and he currently serves as the chief science officer for a company called GRAIL that makes a test called Gallery that we're going to talk about tonight. It's a multi-cancer screening blood test, and it's a very exciting science. But first, Michael, how did you get into genetic counseling as a profession? It's not a profession that a lot of people know about. When in your schooling or your training or your life did you first hear about genetic counseling, and how did your career path lead you in that direction?
Fantastic question. So in college, I'd heard for many years from my mom, happy is the man whose avocation is his vocation. And so I was constantly listening for topics of interest in my didactic education at UNC, and really just fell in love with genetics. At that point, I honestly stumbled upon genetic counseling just through a quick Google search. So looking for different careers, whether it's research or the clinical setting, something where I could continue to learn about genetics in my career day to day.
And what's the training process? What's the how long do you have to go to college? What are the various undergrad and graduate degrees that you have that leads to becoming a genetic counselor?
Sure. So 4-year undergraduate degree, most individuals major in some sort of science, although actually that's not mandatory, or at least it wasn't when I was applying almost 15 years ago. There's a handful of prerequisites such as genetics, statistics, a handful of chemistries like biochemistry. And as long as you had those prerequisites, the actual major was there wasn't a specific requirement for the major, I should say. The schooling itself is a 2-year master's degree. And so the first year is at my program. So I went to the University of North Carolina at Greensboro. And the first year was very heavy on observing genetic counselors, but then also a lot of genetics, training. So principles of genetic counseling, laboratory medicine, genetics and medicine. And then the second year, you're busy with your thesis project as well as clinical rotations. And so that's when I was about 3 days a week on average in clinic at Duke, Wake Forest, or UNC.
Yeah. And genetic counseling has become, and genetic testing and genetic counseling have become increasingly more important in cancer. I'm an oncologist, and, the number of cancers that have genetic predisposition and the amount of information that we're learning about that has really expanded considerably during my 40-year career as an oncologist. How would you characterize the role of genetics in the etiology of cancer as a cause of cancer, as an underlying background in why patient gets cancer, and the role of genetic counseling in oncology in general?
Absolutely. So cancer genetic counseling has always been one of the major clinical settings for my profession, for genetic counselors. For many decades, we've known about a handful of genes such as BRCA or BRCA that do predispose to an increased risk of developing certain types of cancers. But I would say it's really been in the past 10 years or so with the advent of next generation sequencing, which allowed us to simultaneously screen for a multitude of genes as opposed to one at a time, which not only made genetic testing more efficient and accessible, but also allowed for a reduction in cost. So historically, genetic testing in cancer has been really targeted on that, what we call germline, or genetic mutations, or genetic alterations that somebody's born with that predispose them to an increased risk of cancer. However, those individuals that do end up developing cancer, only a small minority of them actually carry one of those underlying um, uh, germline alterations that increase their risk. So regardless of your genetics, all of us do have a risk for cancer. And so it's been in the past, I'd say, 5 years where we've really leveraged more personalized medicine. So looking at the genetics of an individual's tumor once they have cancer. And that will actually, I think, is a nice segue for today's talk as well, where we're looking at employing something called the liquid biopsy, which is blood-based genetic testing, but instead of looking for mutations somebody's born with, so again, something that you were born with that predisposes you to that risk. Now we're looking for mutations circulating in your blood that actually indicate the genetics of your underlying malignancy.
And that those pieces of DNA genetic material circulating in our blood that we're looking for, those actually are part of the DNA of the cancer cells, correct?
That's exactly right. So we're now through known biological phenomenon, and we've known about this circulating tumor DNA, as you mentioned, for several decades. But it's really just been in the past, say, 5 or so years, where we've harnessed the presence of that circulating tumor DNA and found a way to use it for personalized medicine. So again, for people already diagnosed with cancer, and now pushing it back a little bit further even, and using it as a tool for early cancer screening.
Yeah, exciting. We're going to get into the exciting part. And just to kind of summarize and recap the two different types of genetic testing that you've already referred to. So there's testing to see what are the genes that I as a human being was born with, and do I have any of those genes that were passed on to me from my mom or dad that predispose me to getting cancer. And we call those genes the germ line. Now, in the term germ doesn't mean bacteria or something bad. It's the germination, and it's the genetics that we are born with. So that's the germ line. So when you think about genetic testing to see are you at higher risk for getting cancer, like the BRCA gene in breast cancer, that's the germ line mutations. But the other mutations are looking for pieces of the DNA or the genetics that are in the cancer cells. So the cancer cells genes can also have mutations, and we can also test to look for that. So I just wanted to give that little summary to clarify for those who might not understand what the word germline means. So the rest of the conversation tonight isn't really about our germline mutations or the mutations that we got from our mom and dad, but it's about blood tests that can find in our blood snippets of DNA from cancer cells. And maybe, Michael, I don't know if you want to expound upon that science before we get into the test, or do you think that we've covered the science sufficiently?
No, I think just to highlight what you just mentioned as well. The germline component has been around for 20 years or more, and although it is incredibly important, especially for those 5 to 10% of individuals diagnosed with cancer that carry one of those germline mutations. Again, the vast majority of individuals diagnosed with cancer do not have that predisposition. So again, everybody, regardless of what you're born with, is at risk for cancer. And we know that over the course of the lifetime, it's 1 out of 2 men, 1 out of 3 women will eventually be diagnosed with cancer. So what we're going to be talking about tonight with the applications of circulating tumor DNA, it takes genetic testing not just a step further for screening, but it's also something that will be beneficial to, or can be beneficial to, anyone in the general population. Dr. Deming, you and I did a co-presentation or co-event a few months ago with the American Cancer Society and Cancer Action Network. And one of my favorite quotes is actually from the Cancer Action Network, saying that, the best way to reduce the toll of cancer, and toll everything, economics, morbidity, mortality, is either to stop cancer from happening altogether, which we don't really have that ability at this point, or to catch it early. So things like mammogram, colonoscopy, for certain individuals, low dose CT, or a CT scan for lung cancer. But the reality is, even somebody that adheres to or proceeds with all of those guideline recommendations, we're still missing close to 3/4 of diagnosed cancers over the age of 50. So in that 50 plus age group, over 70 or about 75% of patients diagnosed with cancer, it occurs in a cancer where there isn't a screening guideline.
Yeah.
And so again, the advent of circulating tumor DNA and the development of the Gallery test is a way for us to cast a much wider net. So one test looking for more than 50 different types of cancer at once.
Super exciting. And before we get into the test, just again to kind of level set. So what does screening mean? And screening, so for example, if a woman feels a lump in her breast and goes in to get a mammogram, that's not a screening mammogram. A screening test is when you don't have symptoms of cancer, but you get a test that tries to find a cancer at an early stage. Right now, there are only five cancers, for which there are validated screening tests. So those five cancers are breast cancer, and that's primarily a mammogram, colon cancer, which could be either a colonoscopy or looking for blood or fragments of DNA in the stool test, lung cancer screening with a low-dose CAT scan of the chest for patients that are at risk for lung cancer, and that's primarily smokers. The Pap smear, which is a screening test for cervix cancer. And then prostate cancer, there is a blood test. It's not looking for the DNA of cancer cells, it's looking for a protein. So right now in the United States, those are the five types of cancer that we have screening for. But as Michael said, 75% of cancers in the United States occur with types of cancer that we currently do not have a routine screening test for. And that leads to this blood test that the company GRAIL has developed, that can screen for 50 different types of cancers. So I'll turn it back over to you, Michael. Anything more you want to say about the current screening techniques that I reviewed?
No, just that, and certainly we both can agree that those modalities you just mentioned, those screening techniques, they do save lives, but we needed to think of a different way, hence the emphasis on multi-cancer. So one test, 50 types of cancers screened. It becomes more and more challenging, of course, to recommend an additional evaluation, an additional imaging, or an additional test to start chipping away at that, again, approximately 75% of cancers we're missing right now. So that is why we're here to discuss what we call in medicine a paradigm shift. So rethinking from one cancer screen at a time to multiples, or one test, multiple cancers.
Okay. So would you want to start with background, or you want to talk about tell us, what is the paradigm? Why is this so innovative, and how do you think this is going to change the trajectory of cancer screening?
Sure. So paradigm shift, it can really be twofold in my mind. So again, one is right now the five cancers we screen for, each requires its own evaluation. So its own imaging or test or blood specimen. And again, with GRAIL, we're offering one test that looks for 50 different types of cancer, and it's a blood-based test, so very accessible. I should state at that point that, or at this point in the talk, although we are looking for more than 50 types of cancer, and we are discussing a paradigm shift to multi-cancer screening, at this point, we do not want to have Gallery replace mammogram or any of those other cancer screens that exist right now. So Gallery really is here to complement the screens that exist in the guidelines or in medicine at this point in time. But again, the other paradigm shift is, again, right now, the majority of those screens that you mentioned, like colonoscopy, mammogram, the low-dose CAT scan, we're looking at imaging. So we're looking for evidence of a tumor to show up on that imaging modality. And since this is a blood-based test looking for those very small fragments of DNA from a tumor, you can think of this more as molecular imaging as instead of traditional imaging, since again, we're looking for those molecular abnormalities or those hallmarks that occur in a cancer cell.
And so the general, correct me if I'm wrong, but the reason that there are snippets of DNA from cancer cells circulating in the bloodstream is the thought, not that these are tumor cells, viable tumor cells circulating through the bloodstream, but that early cancer deposits, cancer has to start from one cell, but that human cells die after a period of time. Even a cancer cell will die. And so as a cancer cell grows and then multiplies to 2 or 4 to 8, some of those will naturally die just on their own. And when a cell dies in the body, it releases bits of its DNA into the circulation. And that's what you're looking for with the blood test, correct?
That is absolutely correct. And that's what we mean by circulating tumor DNA. So it's a very concise way of referring to that biological phenomenon you just described. So if we think about the lining of our GI tract, how it's constantly being replaced, or our skin cells, how they're constantly being shut off and we replace them, that is that natural process of cell death and replenishment that you're referring to. So again, it is something we expect to occur even in our healthy cells. And so again, what we've known for several decades now is that in most cancers, even though we think about cancers growing and dividing out of control, which of course is true, some of those cancer cells do also undergo that cell death, that breakdown. And when that occurs, they release the contents within that cell into the bloodstream. Of course, some of the genetic information is inside of those cells, and so circulating tumor DNA refers to that cellular breakdown, and then the abnormal DNA being in the patient's bloodstream. From that point, what GRAIL has done is developed the genetic test, the test that assesses for some of those very common genetic abnormalities that occur across a wide variety of cancer types, and occurs even at early stages, so that we can detect cancer early at a point where we can potentially change the trajectory of that patient's journey.
Right. So the whole goal of screening is the theory, and it works out in at least 5 cancers, that if you find a cancer before it causes symptoms, that you'll find it at an earlier stage when the likelihood of curing the cancer is greater than if you waited until a patient had symptoms.
Correct.
Yep.
Correct. Unfortunately, most of especially for some of the more aggressive cancers, ovarian, pancreatic, esophageal, lung cancer, liver cancer, not only are those very aggressive in nature typically, but unfortunately the majority of those are either asymptomatic or have a very non-specific presentation in stage 1, stage 2. So the vast majority of those cancers will not present or be picked up until stage 3 or stage 4, when of course it becomes more difficult to offer treatments with curative intent.
Yeah. So let's jump into the blood test. How much blood do you have to have?
Right now, we're recommending two vials.
Okay.
So think about going to your primary care provider once a year and having a tube or 2 drawn for things like cholesterol or a simple blood count. So this is an additional 1 to 2 tubes of blood. So not very much is required.
And then does the blood get sent off to a reference lab somewhere in the country to have the actual analysis done?
The blood specimens are sent directly to GRAIL. We do have two laboratories, one here in my backyard in Research Triangle Park, and then a second laboratory in the Bay Area of California. So we do process the samples in those tubes from start to finish, with results being reported about 10 to 14 business days after we receive the specimen.
Okay. And again, you're looking for snippets of DNA from cancer cells. And and you don't have to get too technical, but what's what's the process of finding those? I mean, you send them, you don't send them through a cell counter. You send them, what sort of an apparatus finds those snippets of DNA?
Sure. So we're performing, and this is going to get a little technical, but we're performing something called methylation analysis. That's a very fancy way of referring to which genes are cut on or cut off. So to put it, and again, methylation is a very normal process that occurs in all of our cells. If we go back to, say, high school biology, you might recall that our bodies start from a single cell during embryogenesis, and therefore, and then when that cell divides into 2, 4, 8, 16, all of the genetic information and all of the genes are copied into those clonal cells. So essentially every cell in our body contains all 20,000 genes. But of course, we don't need all of those genes on in some of those cells, either ever, or we don't need them on at certain times. So methylation refers to that process where genes are cut on or off, which again indicates the role that that cell or those genes are performing. So as an example, the genes that encode for digestive enzymes, they are present in my skin cells, but of course I don't need digestive enzymes in my skin, so they are permanently methylated and cut off. Methylation can also be something that fluctuates. So we discussed, Dr. Deming, how the lining of our GI tract or how our skin is programmed to be replenished. So for those cells to die off and then to be replenished by new cells. And so methylation, of course, causes those cells to divide at specific times so that that replenishment occurs. Now, of course, if that cell replenishment goes awry, so if methylation goes awry and genes are cut on that cause uncontrolled cell growth, then that is by definition a tumor. So it's those very specific changes to methylation, as an example, that we are looking for in a patient's blood specimen. And if we see some of those methylation abnormalities, then it indicates a very high probability that it's caused by an underlying cancer process. Now, what's also great about leveraging that methylation is you can imagine, as a physician yourself, if we had a blood test that screened for 50 cancers and all it did was come back positive, and then you had to go looking throughout the entire body, that would cause quite a bit of anxiety and very high healthcare costs. But we are also able to leverage those methylation patterns that are set during embryogenesis. So again, genes being permanently cut on or cut off, reflecting, the role that that cell will eventually, and that organ will eventually perform. So when we do detect abnormalities consistent with cancer, we can then use the same blood specimen that's already submitted and then apply a second algorithm or analysis that says this is the most likely site of the patient's cancer. So it's positive, and you should go looking in the pancreas or in the liver. So again, the next steps are very targeted, since the is informative with that second piece of information.
Yeah, and that's obviously, as you stated, very important, because it would not be very helpful just to be told you have cancer and it's one of these 50 different types. That knowing that there might be a possibility of a pancreas cancer, you would do different imaging to try to look at the pancreas, as opposed to a study that says, well, this looks like it came from the colon.
Correct.
So, would it be helpful to go to the slides next to talk about the actual analysis and kind of what the results are and how you what the results are that come back, and then how once the test results are back that says this is positive, where we go next? But maybe let's go to that slide number 6, George. Here we go. Is this a good slide to
Yeah,
demonstrate?
let's skip ahead just a few where it says gallery performance parameters, if that would be okay.
Okay,
And then one more.
there we go.
So here I can offer some of the high-level performance parameters. So again, our ability to actually detect cancer. Now, there's two different metrics that are used at a high level for any screening test. So not just Gallery, but mammograms, colonoscopies, or Cologuard. So we have sensitivity and we have specificity. And what I'll say first is that Gallery has really been optimized for specificity, meaning that we wanted to have as few false positives as possible. So in other words, with a screening test, we wanted to ensure that most of the time when a patient received a positive result, that it did actually indicate an underlying cancer, and that we weren't just saying you might have cancer over and over and over again and causing false alarms. So that was a really important metric for us to reduce harms and anxiety for a general population screening. What you'll see is that we achieved a specificity of 99.5%, meaning that there's a false positive rate of only 0.5%. So what we would expect is for every 200 patients that proceed with Gallery, only one would receive a false positive. And Dr. Deming, if we compare that to some of the screens that exist today, something like Cologuard as an example, that test on its own has a specificity of around 86%, I believe, 86 to 87%. So we were quite pleased to achieve such a high specificity while not screening for one cancer, but screening for more than 50.
Yeah, and mammograms have false positive of much higher than that. I mean, I don't know the number off the top of my head. Do you know, Michael, the false positive? If you get called back because that mammogram wasn't totally normal, that false positive rate, do you know that off the top of your head?
I believe it is 11%. Yes, it is right at 10 to 11%.
Okay. So when it's called, well, something doesn't look right, we need to do something more. So the normal screening tests we have already have a much higher false positive rate or false alarm than the Gallery test does. And then I think you were going to talk about the difference between sensitivity and specificity.
Right.
And we've just been talking about specificity. So if your test is positive, 99%, 99.5% chance that there is cancer in the body. And
so
then
specificity just means, that very rarely would it, if we consider everybody who proceeds with Gallery, very rarely would somebody get a positive result that didn't actually have cancer.
And then explain what sensitivity is.
So sensitivity means if a patient does have cancer, what's the likelihood that we will detect it? Now, what's a little bit different here between the specificity that's highlighted in red and our sensitivity is our specificity is fixed, meaning that that is the same metric for, or it's a single metric for all 50 cancers. So it does not change. The sensitivity, though, between the individual cancers does change, meaning that for some cancer types, Gallery, this multi-cancer test, screening test, performs much better. And then for some cancers, we have a lower sensitivity. So just to put it frankly, it performs worse. The general trend that we see, though, is that a more aggressive cancer type, so some of those that we've already talked about tonight, your lung cancers, esophageal, pancreatic, ovarian, those more aggressive cancers, given their aggressive biology and nature, they tend to be undergoing higher levels of that turnover or cellular death process that we've discussed previously. So that means there's more of that abnormal circulating tumor DNA in a patient's bloodstream, for those more aggressive types. So essentially, what the trend that we see is more aggressive cancer means we have a higher likelihood of detecting that cancer even at an earlier stage. And then it's some of the more I hate to use the word benign, but for lack of a better term, some of the more slower growing or more benign cancers, like indolent prostate cancer, as an example. It's those cancers which, again, indolent means there's not a lot going on, right? And so it's those cancers that perform worse. So we have lower sensitivities for the cancers that are going to be more slower growing, and then higher sensitivities or higher ability to detect that cancer, typically for those more aggressive types.
Yeah. And so, Michael, the average is that 51.5 of all the different types of cancer?
That's right. But if we click one more slide, you'll see that trend that I highlighted a moment ago. So this is a little bit busy, but if you look at the 12 cancers along the right here, and you've heard me mention of some of the very aggressive types like stomach and lung and liver, you'll see these 12 cancers alone account for about 2/3 of cancer-related deaths in the United States each year. And you'll also notice that outside of colorectal cancer, of course, and then a small number of patients do proceed with lung cancer screening, but not the majority. So again, the majority of these cancers in today's world without multi-cancer screening are diagnosed in an advanced stage 3 or 4. With Gallery, although I mentioned the aggregate sensitivity, or that on the prior slide, the overall sensitivity was just over 50%. If we consider just these 12 very aggressive, clinically significant cancers, then you'll see we achieve 70% sensitivity or 70% detection by an early stage 2. So again, at an opportunity where we can intervene and offer an intervention with curative intent.
Yep. And just stating it in a different way, that 30% of people have cancer, the test is going to say negative, so it's not going to find it. But no test is perfect, and neither is a mammogram doesn't find every cancer. A CAT scan of the chest doesn't find every cancer. Colonoscopy doesn't find any cancer. And as you pointed out, you wanted to have this test with a very high specificity, because you didn't want to have, somebody get a positive result and only 50% of the people who are positive actually have cancer. So it's only 0.5% of people who test positive will not have cancer. But on the other hand, 30% of people who have cancer will get a negative test. So do you sense that over time, as the science develops, that sensitivity might improve, or there's probably some cancers that just don't shed a lot of DNA into the bloodstream because they're really slow growing, they don't die frequently, they don't release a lot of DNA?
Certainly. Part of it is biology, as you mentioned. So if it's an indolent cancer that's not producing a lot of that circulating tumor DNA, then in changing our technology, any blood-based test is not going to detect a cancer if it's not producing that abnormal circulating tumor DNA. One area of research is looking at same phenomenon, so where cancers or tumors are broken down and release that abnormal DNA, but instead of it ending up in the bloodstream, a lot of cancers of the genitourinary tract, so kidney cancer, bladder cancer, that DNA is excreted through the urine. As opposed to ending up in the bloodstream reliably anyway in early stages. So there is research, I should say, outside of GRAIL. There are publications that are looking at whether or not similar tests can be developed with a urine sample to enhance the sensitivity of those urinary tract tumors.
Gotcha. So you'd be looking for the tumor DNA in the urine.
Right. Just because it's more accessible there.
So I should know the answer to this, but I don't, and I bet you do. So the Cologuard test that you do on a stool sample, is part of that test to look for DNA of cancer cells in the stool?
It is looking for a limited profile of genetic abnormalities that are frequent in cancer. I'm not a Cologuard expert. I believe there is also an anemia marker, since anemia is such a
Yep.
common um, risk factor for colon cancer.
So look, it's looking for blood, but it's
Right.
also that particular brand of stool tests. So the old-fashioned stool test was just to look for blood, but the Cologuard also does look for
A
bits of
handful of
DNA.
a handful of genetic markers. Yes.
Yep. And just to repeat, the Gallery test that you do is a blood test, and
Correct.
currently you don't have a urine or stool test on the market for your test.
That's correct. It is just blood.
Okay. So I just had my blood tested. You told me it was positive, and you said, let's do a couple of scenarios. Let's say you said that it looks like I have a high likelihood of having pancreas cancer. What would be the next step?
Yeah, let me back up even
Okay.
one more step, if you will, and just say
Sure.
that again, since we have such a low false positive rate, whether just in case there's a handful of physicians or medical professionals on the call, we expect the majority of Gallery tests to return negative. The verbiage on the report is no cancer signal detected. So on an average general population risk, we expect about 98 to 99% of all Gallery tests to return negative, meaning, as I mentioned, still proceed with any guideline recommended screens such as mammogram or Cologuard, but no additional follow-up is indicated for a negative result. As with other cancer screens, though, like pap smears and like Cologuard colonoscopies, mammograms, Gallery would need to be repeated, and we do suggest an annual basis. So, that can be locked in with the yearly or annual physical. But again, just to establish expectations, the vast majority of Gallery results, 98, 99% at the population level, will be negative.
Good. That's really important parts. Yeah, so that 99% will get a good news
That's right.
that you were not able to detect anything. Doesn't mean that you don't have cancer. We already said it's not 100%, but it has to be very encouraging for those patients who get that result.
Correct. And then for the 1 to 2, and this goes back to your point, for the 1 to 2% of patients that do receive a positive result, as I mentioned, we do provide, since we're leveraging that methylation information, the genes being cut on or off, we do provide what we call the cancer signal origin, which is just a very fancy way of saying where's the cancer likely located. And so if it comes back positive for pancreas, then at that point, we do reference the literature, looking for the most sensitive, so the most reliable ways of detecting those particular types of cancer. Now, again, since this is a paradigm shift, a doctor's not going to be able to go, into the literature and say, the Gallery test says pancreas, so I should do this. So we do have to make some, clinical judgments. But as an example, with pancreas, there's something called a pancreatic protocol CT. So if somebody has high suspicion for pancreatic cancer due to traditional signs and symptoms, the pancreatic protocol CT or CAT scan already exists. So a clinician might leverage, might leverage that imaging modality as a next step.
So that the patient's own doctor would order it. Your company doesn't order it. Your company, and just out of curiosity, your company shares the information with the doctor that ordered it, and then the doctor talks to the patient, or do you talk to the patient about the results of the test?
Great question. So the doctor receives the test results, typically by fax or some sort of online portal. I will say the majority of providers, when they receive a positive result, there's an automatic touch point with a member from GRAIL to make sure that the result was received and to see if there's any questions about interpretation of the results or possible next steps. But ultimately, it is the doctor that would then communicate would communicate the results to the patient directly and then recommend the next steps.
Gotcha. And so the conversation you have with the doctor before the doctor talks to the patient, I mean, if you were calling me that one of my patients was positive, I'd probably say, well, what do you recommend would be the next step from the various studies that you've done and the patients you've been involved with? And as you just said, you would share, well, this tested for pancreas cancer, we would recommend that you consider ordering for the patient a CAT scan of the abdomen with a pancreas protocol to look very closely at the details of the pancreas on a CAT scan to see if you can pick up an abnormality.
Correct. And the other thing that we would also highlight is that when a patient receives a positive result, there is a second, this is getting a little high level, but there is a second statistical calculation that is performed with any screening test, not just Gallery. And it's something called the positive predictive value, PPV. And it means that patient that receives the positive result, what is the likelihood they truly have cancer? So again, with something like mammogram, I'm sure several people have gotten that dreaded phone call saying that there was a lump or some sort of abnormality and there's going to be a biopsy. But again, a screening test never means that you actually have cancer. There's typically some sort of follow-up diagnostic test to confirm or to rule out what the screening test suggested. So with Gallery, one of the counseling points that we would offer is that there's about a 40 to 45% chance that the patient does have cancer. So it is quite high. That risk is much higher than, say, somebody that has a positive Cologuard or a positive mammogram, as an example, and it certainly warrants follow-up. But we would want to remind clinicians that it is not diagnostic in and of itself. So next steps, that diagnostic workup and imaging is certainly recommended as soon as possible. But I do think that's an important part of the counseling for the patient as well.
And then what happens if you do the next step and you don't find something to biopsy? Maybe I'm just thinking, as a doctor who takes care of patients with the pancreas cancer, maybe I'd say, well, let's do an MRI, see if a different type of imaging might pick this up since we're highly suspicious that there's pancreas cancer, or an endoscopic ultrasound. I'm just kind of in my own mind wonder how far down the road do you go with more and more imaging if you don't find an abnormality?
Great question. And that's typically one that's kind of a case-by-case basis, again, talking, and typically one that's facilitated between the patient and the provider. So how anxious is the patient? How far do they want to chase that result? But one of the things that we do at GRAIL, which can be used as an additional data point for whether or not that patient's positive result actually indicates cancer or is a very rare false positive, is after a period of time, typically 3 to 6 months, we will offer a redraw. So we will repeat the test using a new blood specimen. And at that point, if the result remains positive, then that lends further evidence to there truly being some sort of malignant process present, and it might be worthwhile to repeat imaging or to consider a different type of imaging, since they all have their own risk limitations, benefits. However, if it does come back negative, then it's again an additional data point where that would suggest that perhaps the first was a false positive, especially if there was a very sensitive imaging modality used in the initial diagnostic workup. So it can get complicated, that diagnostic workup, especially since this is something new and since we're having to use clinical judgment and without guidelines at this time. But again, that's why I typically start with level setting on how often that's going to happen. So false positives, 1 out of 200, and again, 98 to 99% of all Gallery results will return just straightforward negative, which is reassuring information.
So, Michael, with the use of Gallery and all the clinical trials and all of the preliminary testing, what is the cancer that has been found most frequently, or maybe the top 3 that you actually have found when you have a positive. So if you take all the positive Gallery tests that are out there, what are the top 3 or 5 of the cancers?
I don't actually know that piece of information off the top of my head. You caught me.
Yeah, so it'd be a combination of, well, how prevalent is the cancer, and
Exactly.
then how much does it shed? So, obviously the most prevalent cancers in the United States in terms of incidence are prostate and breast and lung and
Mhm.
colorectal. Do you have a feel for, are those the top ones? I would say from what you've already said, prostate is not in the top number that you find with GRAIL,
Right, because the majority are
with
infants.
Gallery. Yeah. How about breast?
Breast is one where we have we actually have had enough patient specimens where we can start to parse out some of the, not just breast cancer, but different types of breast cancer. Um,
So I would imagine you're not going to find ductal carcinoma in situ.
That's right. Those
So,
low shedders, those DCIS or ductal,
yeah, and hopefully, yeah. I mean, I shouldn't say hopefully. Probably you're not going to find a grade 1 ER positive, PR positive breast cancer in a 75-year-old that's, a very favorable, slow growing.
That's exactly right. It's very unlikely. And for that reason, that's why, again, we recommend that this complements mammogram, because again, the algorithm we have in place, since we're juggling so many different types of cancer, sacrificing sensitivity on breast cancer was okay, since we have mammogram as a backup. And again, the real power, the clinical utility of Gallery is in those other 45 plus cancers where there's no screening modality available. But to your other point, a more aggressive type of breast cancer, so something that is like a triple negative or a hormone receptor negative cancer, we do see certainly higher levels of circulating tumor DNA and tumor shedding. So that tumor turnover we talked about. And so Gallery actually does perform with higher sensitivity in those more aggressive subtypes based on the data we have.
We've also mentioned ovarian cancer, often referred to as the silent killer, because patients don't have symptoms and we don't have great screening. Do you want to say anything more about ovarian cancer? And so if a woman had a Gallery test done and it was positive for ovarian cancer, what would be the next step? I mean, some form of imaging,
Mhm.
ultrasound, CAT scan, MRI. Anything you want to say about ovarian cancer?
Sure. So you're exactly right. Ovarian cancer is one that is, kind of that silent killer. The data we have suggests that, and again, these are individually small numbers since each individual cancer type is rare. But in one of our initial clinical trials, we observed 50% sensitivity for stage 1 and 80% sensitivity for stage 2. So both early stages with ovarian cancer. As you mentioned, oftentimes there's some sort of ultrasound of the abdomen when there is a positive result, suggestive of ovarian cancer. So transvaginal ultrasound as an example.
Okay. So I'm looking at the time because we've got a live studio audience, and I'm sensing there's going to be lots of questions. One thing that I think deserves to be said is that you guys are continuing to do lots of research, and that for a screening test to be validated as meaningful and useful, we need to show that having the test and using it as designed leads to a reduction to something positive, and best case would be to a reduction in the death rate of cancer by doing the screening test versus just doing what we're doing now in terms of surveillance and screening. Would you agree with that, or how would you phrase it?
No, I absolutely agree. So one of the long-term data collection points, if you will, is looking at not just our ability to detect cancer, but then what impact does that make? So again, right now we have anecdotes that say catch cancer early save lives, but many guideline influencers or other governing bodies want to see the direct impact of early detection via Gallery itself and the implications that have on mortality, on morbidity, and on cost. We do at GRAIL have an HEOR, Health Economics and Outcomes Research team, many epidemiologists that are much smarter than me that have modeled data and suggested that Gallery would more than triple the number of cancers identified through screening each year from the number we identify today, which of course would result in a reduction in cancer mortality of approximately a third. But again, that is model data, since of course this long-term data does in real world, as you mentioned, does take time to collect.
But so we think that if it plays out according to the models, that we might triple the number of cancers that we find annually, and that we would reduce the death rate by a third.
Correct.
Okay. Which would be, a huge improvement. And so that data is continued to be collected and at some point gets submitted to the appropriate governmental and insurance entities that ultimately decide that it has met a level of evidence that shows it's of value and would ultimately then be paid for by insurance and put into standard use across the United States and the world.
Right.
Yeah. A lot more we can talk about there, but let's open it up to questions. So we've got a live studio audience here, and we'll start with them. And those of you that are watching us live streaming, if you'd put your question into the text box or the comments section, and we will be monitoring that. But we'll start with questions here in the audience.
Yes, I have a question, and segging away on the early detection. To kind of give you a background, my father in 1999 got diagnosed with diabetes when he fell, and they said, "Oh, he's got diabetes," but unfortunately, we didn't understand other symptoms we were not alarmed or alerted to, and it turned out he had pancreatic cancer. Of course, it came was kind of late, and then he died no more than like 3 or 4 weeks later. So with that being brought up, is there now determining for pancreatic cancer? Is there an early detection now? Now in the present, have we improved on that?
So there is not a universal guideline screen for pancreatic cancer at this time.
Yep. So yeah, this is one of the classic ones for which this test, if it pans out, would be very important, because right now, as Michael said, there is no screening test for pancreas cancer. So those patients who are at super high risk based on family history or germline mutations that might increase the risk. So mutations that we have in our body, we do sometimes, but it's not universal, but we sometimes, with patients at very high risk because of family history or genetic mutations, might do CAT scans of the pancreas or MRIs or endoscopic ultrasound, but there is no screening test for average risk patients for pancreas cancer. So, other questions?
Is there an age where you would recommend?
Good question. Yeah. So if somebody wants to get this, I assume you're not screening 10-year-olds. What's your criteria for age? What's the youngest age, and is there an age at which you should stop doing these sorts of tests? Should my 100-year-old? No.
Great question. Just like our current screening modalities or screening guidelines have age recommendations, so starting colonoscopy now at 45 or mammogram at 40 to 50, depending on the guideline you reference. We also have that age recommendation with Gallery. We set it at age 50. But highest level is that we would recommend or suggest Gallery in an increased risk population. And of course, every provider and every patient defines increased risk differently. Some providers say, I want to offer this to everybody starting at 45 or 40. Some stick to 50, which is what was directly studied in our GRAIL clinical trials. And then we have other risk factor criteria, such as the family history that was just referenced, or that germline status. So again, the small number of individuals that are born with a higher risk of cancer. Significant smoking status. And then another unique population is cancer survivors. So an individual that's had a prior cancer and has finished treatment and is presumed to be cured of that cancer. We do know that unfortunately there is a higher risk for those individuals of a second primary cancer. And so we would consider that increased risk and eligible for Gallery.
Okay.
But again, punchline is increased risk. And we specifically studied at GRAIL age 50 and above.
And you said the initial study was 50 and above. Did you have a top age in the initial study?
We did have a top age, but typically that one also is escaping me off the top of my head. Typically, it's a conversation about the, as with PSA screening, right? The overall health of that patient. If a patient is 102 and thriving, and would be able to survive a surgery for a pancreatic cancer, then that's again a patient provider conversation to have. However, if the patient is 50 and already on palliative care for something unrelated, then Gallery is not going to add a lot of clinical utility. So I think it boils down really to that provider-patient conversation.
Yep. Okay. Other questions?
Yeah. So, Michael, it sounds like Gallery is super cool, and you have a super cool job.
Thank you.
My real question is, let's say I suspect that I might have cancer, for instance. And I go to my primary doctor and say, I think I need a Gallery test. I bet you my doctor is going to say, what's a Gallery test? So with your expertise here, and how are you getting the word out to primary doctors to say this is available and it is a really nice screening test?
Yeah, so we do have boots on the ground, if you will. So individuals like myself all over the country with scientific backgrounds doing educational sessions such as this. There is also a commercial team separate from mine that's really directly in the provider office or in the healthcare system office, getting the word out, discussing the availability of the test. And then, of course, the commercial team is more involved in the contracts and getting accounts set up. We do also have a very busy customer service team. As you can imagine, there's been a lot of press, even on national news, about Gallery. And so we've had patients and providers calling customer service directly. But ultimately, anybody that inquires about Gallery, or a provider, I should say, that inquires about Gallery, is going to be channeled to myself or another scientific professional at Gallery at GRAIL.
And Michael, let me just throw in, from a clinical perspective, I'm so excited about the science, and I'm really looking forward to all of the trials coming to fruition and proving that it actually does save lives. But the current state of affairs, and correct me if I'm saying any of this wrong, is it's not FDA approved for insurance companies to pay for it yet. So if you wanted to get it and you talk to your doctor getting it, I just met with the GRAIL representatives yesterday. It's $949 out of pocket, not paid for by insurance. And right now, we can't say that getting the test and finding a cancer is going to lead to better outcomes. There are lots of theories and lots of modeling that suggests that it's true, but the reason insurance isn't paying for it yet is it hasn't met the scientific criteria of showing benefits. So you can get it done, but you're going to pay for it out of pocket, and we can't absolutely prove yet that it's going to lead to better results. But I mean, one of the reasons I have Michael on the show is I'm excited about the science. I know that they're working diligently to amass all of the data to show how it can help reduce the burden of cancer. And they're also not just looking at the science of how many people die and how many people live, but what's the cost consequences of, having the test. And we're talking not just the cost of the $949, but the how many thousands of dollars to do a pancreatic CAT scan or an endoscopic ultrasound. So I just want to throw that in that this is exciting, and I have no doubt that it's going to find its way into practice, but it's not quite there yet, and that's why insurance doesn't cover it for the most part. Do you want to say anything more or elaborate or clarify anything I said there, Michael?
You're absolutely correct. You're absolutely correct. It is, of course, considered experimental, despite the multitude of peer-reviewed publications and the continuing efforts of putting additional publications in the literature, in the medical community. In regards to FDA approval, we do not have that, as you mentioned. However, it's actually very rare at this point in time for any sort of genetic test or molecular test to have FDA approval. There's a separate governing body called CAP and CLIA, which operates really under CMS, so Medicare, Medicaid. And so we do have all of those credentials or credentialing in place, just like the genetic testing for BRCA or BRCA that's been around for decades. So we do meet those industry standard criteria.
Yeah. So the science is sound. Nobody denies the science and the ability to find these DNA. It's what hasn't been shown yet is that finding the circulating tumor DNA at an early stage leads to better outcomes.
That's right.
But the science is sound, and the laboratory science has already been proven to be true, that you can find those circulating tumor DNA, and that you can validate that that's the case. You know what? We are out of time, and there's lots more questions. I think I'm going to have you back again, Michael.
I'd be happy to return.
Yeah, we really value not only your scientific knowledge, but your great communication skills and helping to explain this very complicated new test. I know it's going to change things. And I have to say, it was on my favorite news program, NPR, Morning Edition, like 10 days ago. So,
We've been busy.
Yeah. So thank you, Michael, and I really appreciate it. And thanks all of you for attending this evening. If you know someone that would benefit by listening or watching this program, beginning tomorrow, you can watch it again or have invite someone to watch it on the Above and Beyond Cancer YouTube channel. It will also be available for watching on demand at the Mercy Cancer Center website. Thanks again for joining us, and please join us again next week. Thanks, everybody.